Hi, this is Brian Kim. I want to share with you case number 265 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique so that you can refine your technique and do the very best for your patient. And so this is a Catarock, a fairly dense cataract. You're going to see there's a posterior plate, and I'm trying to crack. But the nice thing about this technique is using the scissoring chop technique to safely amputate the posterior plate, which is essentially turning the chopper sideways, getting underneath the lens, and then pushing the phaco tip and chopper together, amputating that posterior adhesion, the posterior plate phenomenon. And this very easily and effectively deals with that posterior plate phenomenon when you're dealing with these dense cataracts. And then you can see at the end, this patient's going to have some zonulopathy. But rather than placing a CTR, which doesn't, again, provide any support in the short term, it does protect you and maybe give you an opportunity to lasso the lens with a scleral fixation technique around the CTR. Late, I decided to place the Sensor AR40 lens because in my mind, if I do have a late dislocation, my best technique and best approach is really to perform a Yamane scleral fixation technique using my modification with the AR40 lens. So this is the eye. You can see a fairly dense cataract. You can see the exposure of the eye is somewhat limited in this Lieberman speculum. And why is that? It's because the Lieberman is too wide for some eyes. It's too wide. And because it's too wide, it doesn't open the speculum in a vertical orientation so well. But look at this narrow wire speculum. And because it's a narrow wire, look how much exposure I have now. You can see so much more of the conjunctiva and sclera superiorly and inferiorly, which is so much more important when it comes to cataract surgery and lens disassembly. Not to mention, you don't want the lids near your surgical field. You see I have excellent draping, and now I have those lids way away from the action. Using the cotton tip to steady the eye, and this is a corneal marker which will help me to center and size the rexus. Using that cotton tip, I'm controlling the eye, and this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is the premium angled diamond blade by Diamatrix. I have no financial interests. This is the best paracentesis diamond blade I've used to date. This is intracameral epinephrine and then some intracameral air with some trypan blue. I'm trying to paint the anterior capsule surface, and I'm just painting using the cannula to brush the dye on the anterior capsule. You do not want to push too vigorously because that dye can creep backward towards the vitreous space by seeping between the zonules, and then this will obscure your red reflex. I don't need the red reflex when I do cataract surgery, but you certainly don't want to have that dye in the posterior segment if you can avoid it. So very carefully, just pushing gently and rolling the cannula on the anterior capsule, pushing the dye and the bubble out with the dispersive viscoelastic cannula. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I turn the eye towards me with the cannula, and then I enter. Very good control with my incisions because I always use 2-point fixation. And these are the Moria sharp tip microrexus forceps. These are really excellent forceps to puncture through, grabbing the right side of the tear, going around circumferentially, grabbing and re-grabbing. I like to have that cannula there, even though it's not doing anything right now, in case I have to push more viscoelastic, or if I have to turn the eye in a certain direction. The cannula does afford me extra control as I'm doing the rexus. Not only just for the rexus, but through a lot of the techniques that I do that require just a one-handed maneuver, I still like to have that second hand actively helping me just in case something does happen. Again, excellent control with these microrexus forceps, minimal OVD egress, and a well-centered and sized rexus. Burp some viscoelastic out. And this is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, turning the tip down, jiggling it just a little bit, and then pushing the barrel to create a nice hydrodissection wave here, lifting the lens up, effectively decompressing the bag. By decompressing the bag, I'm able to loosen the lens up. Making sure I have good exposure. lifting the incision with the chopper, going in with irrigation off to minimize Decime's trauma, removing the surface epinuclear material first, and then I'm going to show you the terminal chop technique. I'm turning the bevel up. I'm going to sculpt. I'm sculpting a central trough, no different from the standard stop and chop technique, but I don't have to go all the way down with this technique because this is not a standard sculpting technique. Remember, sculpting surgeons like to crack from the surface. If you try to crack from the surface when you have a dense cataract like this and a posterior plate phenomenon, you're going to have the Pac-Man effect, which means you can crack from the top, but it's going to be hinged at the bottom because of the posterior plate. This is a very ineffective way to try to crack and separate a lens. I'm turning the lens 180 degrees apart and I'm sculpting some more. Again, you want to make sure you get good sculpting, especially in the central dense area. You're trying to remove the central dense core, and then I'm going to chop from the terminal side. This is different from the standard sculpting surgeons. Again, instead of trying to crack from the top, I'm going to fracture the terminal edge. By fracturing the terminal edge, by placing the chopper around the lens equator, I'm able to fracture it, positioning the phaco tip deep. And by fracturing the edge, you have a through and through chop all the way. And as I'm trying to separate, I'm able to get some leverage. But you can see here, it's not fully cracked. And that is because I have a little bit of a posterior plate phenomenon. But I'm not going to perseverate. I'm not going to really make a big deal out of it. I'm going to turn the lens 180 degrees here. And then I'll try to sculpt just a little bit in the center as well to see if I can just create some separation in the posterior plate. But again, I don't want to get too close to the posterior capsule. It's really not worth the risk. So I'm switching back to bevel down and perform another terminal chop maneuver. Placing the chopper around the contralateral equator, fracturing the lens between the phaco tip and the chopper, cracking, and I have now good separation. There's still an adhesion on the posterior aspect. But again, because of what I said earlier, I'm very confident that I can separate the posterior adhesion, performing that scissoring chop technique. I'm sliding the chopper around the right heminucleus, hooking the peripheral lens, pulling it centric toward the phaco tip, and fracturing the right heminucleus in half, and that is a cross chop. I'm switching to quad mode, lifting that first quadrant up, crushing the lens between the instruments, and then emulsifying the lens pieces. Again, I am in the dense mode setting because this is a dense cataract. Again, by flanking the lens piece, you're able to fracture the lens in half at the densest most point by strategically placing the instruments around the densest point. So I got that first quadrant out, but this is when I'm going to employ the scissoring chop. You can see there's still an attachment. I'm placing the chopper around that second quadrant, pulling it centric toward the phaco tip, fracturing the lens in half with another cross chop maneuver. But here I use some vacuum to lift that fragment up, get underneath the piece with the chopper, turning it sideways, and here's the amputation. Amputating that posterior adhesion. Again, that's a scissoring chop maneuver. Again, I'm amputating that posterior adhesion, thereby effectively and easily and strategically conquering the posterior plate phenomenon. Grabbing that piece up with some more vacuum, getting underneath it with the chopper once again, turning it sideways, and by getting underneath it, I can effectively amputate that posterior adhesion right here. I'm just driving the phaco tip over, and I'm shearing off the lens piece by bringing the instruments together. And that's what I mean by scissoring. I'm really talking about a shearing force because I'm shearing the phaco tip against that chopper, and it amputates that posterior adhesion. Turning the second heminucleus in front of me, placing the chopper under the rexus edge, contra-incisionally, the phaco tip deep, fracturing that second heminucleus in half, separating it here. Again, there's a little bit of that posterior plate phenomenon, cracking it and cracking it, getting around that third quadrant with the chopper, hooking the lens peripherally, using some vacuum to lift it a little bit up. By lifting it, I'm able to more effectively fracture the lens in half by crushing the lens between the instruments, grabbing that fragment up with some vacuum, again using crushing forces, emulsifying that lens piece, grabbing that piece with some vacuum, and then crushing it between the instruments. I'm very carefully placing the chopper around that lens piece, making sure I'm not catching the rexus edge, placing that phaco tip deep, and then amputating the lens in half. You can see there's still big pieces in the bag. I'm just trying to be very careful as I'm disassembling the lens pieces. I don't want to go pedal to metal in these situations, especially when I'm concerned about weak zonules. But again, there's still a little bit of that posterior plate phenomenon. So I'm placing the chopper around that lens piece, underneath it, turning the chopper sideways, and then shearing off the attachment by pushing and driving the phaco tip against that chopper. That shearing force amputates that posterior adhesion right there. And so that's the thing in this situation. I have a posterior plate, but using that shearing technique, tucking that chopper underneath the lens piece, turning it sideways, that chopper, positioning the chopper so it's right underneath the posterior adhesion, and then driving that phaco tip against the chopper and shearing off any attachments between the chopper and the phaco tip. That shearing force allows me to shear off that posterior plate adhesion, and I just keep doing that throughout the case. And so this is the last fragment, using some vacuum to grab it, crushing the lens between the instruments, crushing the lens once again, start eating up all the pieces. These are the final pieces. I'm always mindful of the capsular bag in these situations, keeping that chopper deep. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start subincisionally, removing the cortex from anterior to posterior. With these dense lenses, I'm always concerned about zonulopathy, so you don't want to use extreme high vacuum when you might accidentally grab the capsular bag. Carefully placing the port over the cortical material and then activating the high vacuum. Polishing the posterior capsule, you can see there's a lot of puckering of the posterior capsule, which is a sign of zonulopathy, but not terrible. The bag looks pretty good. The pupil's pretty good size, so I don't feel like there's a terrible amount of zonulopathy. But again, with dense lenses, I know that there's some level of zonulopathy. So instead of using a single piece acrylic lens, instead of doing a CTR, I decided I'm going to use a Sensar AR40 lens in the bag. And if down the road this patient ends up with a late IOL dislocation, I can do a Yamane scleral fixation technique with my modification on the AR40 lens. And pushing the cohesive viscoelastic to fill the bag, polishing under the rexus edge with the sweeper, and I use the combination Singer Coke sweeper. I feel like this is the best sweeper. It's got the best angle as well as a really large paddle to get most effective sweeping. Pushing some more cohesive viscoelastic to fill the bag. And then I realize here, since I want to use a Sensar lens, I have to widen the incision. My incision is typically 2.4. This is a 3/0 blade, so I'm going to widen the incision with the 3/0 blade. So there we go. And now we're going to go in with the Sensar lens. This is the J&J cartridge. I go in, bevel down, and then I turn the bevel facing to the left, making sure the leading haptic goes into the bag, pronating my wrist to allow the optic to come out in the proper orientation, delivering the trailing haptic into the bag with the Maltzman pusher. There we go. So now the lens is completely in the bag. Go in with irrigation off, activating irrigation, getting underneath the lens, removing all the viscoelastic from within the bag. You can see I'm using the purple sleeve. The purple sleeve will minimize significant fluid egress through the main incision, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a dense cataract, a Catarock. Despite quite a bit of sculpting, despite doing terminal chop on both sides and getting effective cracks on either side, the central dense core was still there and there was a posterior adhesion. But rather than trying to sculpt some more and creating more problems and sculpting near the posterior capsule, which to me is really unnecessary risk, I performed that scissoring chop maneuver, which again, the scissoring means I'm shearing off. You know, the blades of a scissor don't cut by just cutting. They're shearing because there's shearing forces. The blades are shearing against each other, and that's what causes a cutting. So that's why I mean by shearing, cracking the lens piece, and there's that posterior adhesion. I'm able to get underneath the lens piece, turning the chopper sideways, sliding it down towards that posterior adhesion, and then taking the phaco tip and shearing it against the chopper. And by using that shearing force against the instruments to one another, just like the blades of a scissor, I'm able to shear off that adhesion. And I kept doing that over and over again, very safe, because I'm turning the chopper sideways. I can visualize exactly where that adhesion is. I'm able to very specifically apply that shearing force with the phaco tip over the adhesion and amputate those adhesions. And then I just use mechanical fracturing techniques all throughout the lens disassembly on this posterior plate dense cataract. I place a sensor lens in the bag, and I like the AR40 lens for this reason, because if there is a late dislocation, I can use my modified Yamane technique to very easily and effectively scleral fixate this sensor lens. And by doing it this way, I'm avoiding a much bigger surgery, potentially more complex surgery of explanting a lens that doesn't belong there. Instead, it's better to reposition the lens that's already there, which I can do quite well with this AR40 lens. Fortunately, the patient was seeing wonderfully post-op day 1, and she was very happy. So I hope this was helpful to you, and I thank you for your attention.